right, good afternoon, everybody, and welcome to session 4 of our Telehealth 101 Affinity Group. This will be the final session of the Telehealth 101 Affinity Group today, so it's going to be some Q&A for all of you to see what our next steps need to be and kind of where we need to head from here. So thanks for joining us. As always, we've tried to make the information as up to date as possible, and I think we've tried really hard with the help of our telehealth network partners and our stakeholder group to give you all as up to date information as it's changing. So we just want to thank all of our stakeholders for helping us do that, and for an effort like this really takes everybody's eyes and ears. So we definitely appreciate all of your help there. I think hopefully you all are aware now, you don't need to mute your microphones. We've muted everybody. You can put your questions in the chat box or in the Q&A box for the session. We will record and send information to all the participants. And of course, especially today, as we get to the end of this, we would like to know what everybody has learned through the Affinity Group process. If you have any outstanding questions or barriers that you would like to address, and that kind of thing, that would be helpful to share in our session today. So for session 4, we're really talking about the next steps. So for all of you, we're just going to do a very brief overview of chronic care management, mental health care, and what's in store for the post-acute care setting in the way of an affinity group, and what education needs to maybe come next to support you in going to the next level in some of these areas. So right now I'm going to turn it over to Dr. Arzubi, who runs a telepsychiatry practice, and for just a brief overview of that, and to see if there's interest in more discussion on that later.
Oops. Great, thank you. So thanks. So again, this is Dr. Arzubi. I'm a psychiatrist, both board certified in child and adult. And so, yeah, so interestingly, I was working at Billings Clinic until November, and actually left in order to start a virtual practice. So that the interesting timing. So I've been doing a lot of research into models, technologies, and so forth. So I'm happy to answer questions. Also, kind of looking at different sort of EHRs that are out there related to mental health, doing just a ton of research. It's been really interesting. So essentially, what we're doing is we've created a telepsychiatry practice called Avicenna. So it's spelled Avicenna. Here, I'll spell it out. And Avicenna.care. So this is the website, but let's call Avicenna, and really it's a virtual practice where we have a few psychiatrists and psychiatric nurse practitioners, really focused on providing psychiatric care in Montana. We have they're mostly Montana-based folks with some from outside of Montana, but we're, our goal is to really focus on Montana, and sort of aspirational goal is to have telepsychiatry available in every healthcare setting in Montana by 2025. That's our hope. And given how quickly things are emerging in terms of breaking regulatory barriers and hopefully reimbursement barriers, I'm hoping that's not too aspirational. It's something that's actually doable because the technology is there. And also, as we think about our focus is going to be psychiatry in terms of sort of assessment, treatment, and medication management. And I'm a big believer in psychotherapy, and I hate prescribing medication without therapy in place. Our goal is going to be really focusing on prescribing, on medication management, because that's kind of one of the things that is really difficult to access, really people who are good at medication management and psychiatry. So that's going to be our focus. And our focus is going to be on we're going to be able to sort of look across the different levels of care. As you know, we've talked from time to time about the entire continuum of care and sort of risk stratification or prioritizing patients. We hope to make our sales available in primary care settings, as well as specialty mental health settings, and in emergent settings, and possibly inpatient. So I'm hoping to hire people and work with people who are flexible and are able to see people no matter what setting that's in. And what's nice is with technology, if we have a virtual practice, so for example, if there's an outpatient clinic that in a primary care clinic that needs an assessment, or a provider can do that and then turn that off and then go to an urgent care setting, turn that off and then go to another place across the state, and really be more efficient with deploying clinicians. I feel strongly that in a few years we're going to see barriers continue to fall when it comes to providing. Um, it's really called, and some people might be aware of this word. It's really making healthcare fungible, and what I mean by that is being able to sort of really buy and sell access to care across geographic areas, and something like this this sort of technology is going to make that easier. Um, so yeah, so that's our goal. Again, the focus is this region, and possibly other hard to reach places. If there's no reason our providers wouldn't be able to support some people in Wyoming if that's needed. But again, I really want to focus on rural settings, frontier settings where people are really need this care and it's hard to access, because a lot of telepsychiatry practice that exists are kind of going into areas that are already have per capita more providers, and it doesn't make a ton of sense. So, for example, on the East Coast and West Coast and bigger cities, there are telepsychiatry practices, but the rural settings are the ones that really need it. So, yeah, so that's so that's kind of what we're doing. The EHR we're picking, we're going to be working with is Valent. It's a psychiatry focused EHR, so we're hoping we'll be able to kind of collect good data on outcomes and really focus on quality improvement and really provide high quality prescribers who we want to focus on avoiding polypharmacy, overprescribing, accurate diagnoses, and that sort of thing. So yes, that's a little bit about what we're doing, but I'm happy to answer questions, sort of big picture, small picture.
Great, thank you. And I did kind of put a question for the group in chat, to let us know how you think we can expand access to telebehavioral health in our region. What are the needs that you are all seeing out there to fill gaps? I know that in our states, mental health care is a huge gap. There just aren't enough providers, and so how can we start to fill that using a telehealth model? Open to some ideas.
And again, I guess one of the things that as people are thinking about questions is, if we can create, all of us in any practice, if we can create a really compelling model for people to get excited, there's no reason we can't recruit people from outside of Montana to deliver some of these services, because we just don't have enough providers in Montana or in Wyoming alone or in Alaska alone to be able to do this. And especially because, well, Wyoming and Alaska, for example, don't even have psychiatry training programs, right? Montana is just starting one. And so those are often big sources of recruitment that these states don't have access to. And these are 3 states with the highest suicide rate. So, why aren't we going to other states and recruiting talent from there? They can live there, they can stay at home, live wherever they are, but let's have them focus on our region and get access to care. Looks like there's a question. Are you using a particular platform for your sessions, such as Taito Care, or is this through your EHR? So, good question. I'm keeping it separate. So I'm keeping the EHR and our video connections separate, because I found that the EHRs, they often limit you. They don't have a lot of flexibility. So you have to link. One particular session to one particular video, and it can be painful. And so, because one of the things that we're trying to do is provide telepsychiatry not only into healthcare settings, for example, primary care or mental health centers, but also into the home. For example, one of the things I'm doing right now is trying to work on a contract so that we can be one of the community providers for the VA for veterans. Right now I'm doing a lot of disability evaluations for veterans through a third party, and I'm finding that a lot of these guys and women who I do evaluations for disability evals aren't getting even the most basic mental health care. And I think that's not shocking to anyone, but I'd like to be able to provide care into the veterans' homes doing this sort of work. So back to your question, I'm going to try to make the video connection as easy as possible. And so what we're going to be doing is we're going to be using Zoom, and each provider is going to have their own account. And so they're going to have their own identifying. So for example, you might know that the Zoom numbers, the meeting ID numbers, you can make them your own. So for example, I have a Zoom ID number that I use. It's an old phone number that I had when I was growing up, but I remember it. And when I created a password that's sort of unique to my room. So each one of our providers is going to have a Zoom account with their unique meeting ID number and their own password. And we're just going to have them send links to either the healthcare facility or to the patient. But I'm keeping that separate from the EHR because I find that keeping it linked to the EHR just it makes it more complicated, and it keeps me it gives me more constraints. Let's see, another question. Moving forward, do you think that CPC Plus would accept referring patients to behavioral health provider via telepsychiatry to be a warm handoff? I don't see, so right now CPC Plus, as far as I know, CPC Plus, right, one of the things that CPC Plus is funding is integrated behavioral health. So I'm guessing the question is, would CPC Plus allow referring patients to behavioral health provider via telepsychiatry? I guess it depends. So a couple things. It depends. I guess my question would be, why not? Why wouldn't they? I mean, even today, right? Let's say somebody's being seen, a CPC Plus organization is seeing a patient via integrated behavioral health, and they're getting paid for that. But then they decide, you know what, that person maybe needs a higher level of care. By seeing them in the primary care model is not maybe not enough, and you want sort of an evaluation. That evaluation can be paid for by Medicaid or Medicare because it's separate. At that point, you're doing a warm handoff for that evaluation, and so that should be that's just a separate psychiatric evaluation. So I guess I don't see why it wouldn't be allowed. So Karen, I'd like to see maybe if you have an additional concern. All of this disruption due to COVID might help us keep things outside the box. Karen, they're also collaborative care using contracted patients, psychiatrists. It might be helpful to look at those models. Yes, and actually, I'm starting to do that with a critical access hospital next week, where we are providing over video. So we are going to be the psychiatric consultant for that clinic, and we will make our psychiatry service available. So, for example, that clinic is going to be doing collaborative care. We'll be doing the consultation once a week for their teams, and then if one of their patients maybe isn't getting better with collaborative care, we will take that referral. We will do the evaluation, and then provide that feedback to the team and say, hey, here's our treatment plan, here are ideas. It looks like we were on the right page, or we were on the right track with assessment and treatment. Or we might say, hey, you know what, maybe we'll take that patient for a few weeks, try to stabilize, and then bump it back to integrated behavioral health. But no, I'm glad, Amber, that you mentioned that. That's exactly what we're doing with one of the outpatient clinics at a critical access hospital. Other questions or comments? I just, as you can tell, I really think there's no limit to what we can do with the behavioral health. At least, telepsychiatry is a very easy use case. Let's see. Thank you. We're a small independent two-provider clinic. We don't have in-house behavioral health providers, so we're contracted with a counselor to do initial warm handoff for triaging. Got it. No, that's great. Yeah. Any other other questions related to this telepsychiatry or telebehavioral health? I guess one of the other comments I can make is my hope is as telehealth and telemedicine matures, as an industry, because let's face it, healthcare involves money, and so it's business, it's an industry. And as telemedicine evolves, I'm hoping costs go down, because right now, if you look at a national telepsychiatry company, the costs are huge. They're very expensive. When I was at Billings Clinic, we were using an outside vendor, and they're very, very expensive because they can charge that, because not a lot of people were doing it. So my hope is, as more and more people do it, the costs go down, and a small clinic won't have to worry about recruiting and retaining a psychiatric provider. They might just be able to share psychiatric providers by working with a practice like ours or someone else's. So they don't have to worry about hiring a whole FTE. They can just sort of share a regional FTE providing psychiatric care. It'll be cheaper, save money, I hope, and improve access.
Great, thank you. So I see there's some interest in telehealth affinity group around behavioral health, and so we'll talk some more about that with our team next week and see what we can do. So those of you that are interested in that, stay in touch, and we'll have more to come on that. If you have more questions for Dr. Arzubi, go ahead and put them into chat. I'm going to turn it over now to Deb Anderson to give a quick overview about patients with chronic conditions, which you kind of discussed a little bit last week, but we just want to offer that as a potential another specialty area affinity group that we may consider. So Deb, I'm going to go over your information.
Certainly. Thanks, Mary. Good afternoon, everyone. It's wonderful to see so many of you still on session number 4, the very last session. And I know we've got some folks from chronic disease prevention programs who are interested in hearing more about how we want to continue to support and utilize telehealth, especially around chronic conditions and our chronic care patients, or even chronic disease prevention. So it's been really interesting, working in Wyoming and Montana. When they said isolate, I kept seeing these posts go up on Facebook that says, Wyoming, we invented, social distancing. We're used to being independent. We're used to being self-reliant. So more than likely, a lot of the people who have chronic conditions have just hunkered down and said, I don't need a doctor. I'm okay. I might be a little bit worried about what's going to happen here, but I'm pretty isolated, so I'm just going to do my own thing. The issue becomes something may come up and they're not, they're not as ready to put a burden on a provider, on a health system, just because they have some simple questions. Well, if they're enrolled in a chronic care management program, the staff members should already be working with them, and it's a wonderful time to reach out and talk to the patients about how they're doing, what questions they have, how are they able to cope with all of the facets of this huge public health emergency. So great way to use telehealth to get people used to telehealth, where their trusted chronic care manager or coordinator reaches out to them and says, hey, I can do a FaceTime session with you, or I can give you a Zoom link, and we can have an interaction, because that also helps them address the social isolation issues. So the other thing is, we had a lot of folks who were worried about not bringing in their chronic care patients into the clinics, maybe just for blood pressure checks or for weight checks or anything like that. We've actually tried to help people get some equipment that can be taken out, scales and blood pressure monitors, because we want to make sure that these people continue to engage and stay informed and connected to their healthcare providers. So our recommendation was, don't cancel your appointments, but go virtual and make sure that you are continuing to speak with all of your patients who might be, they're worried well, but will be at-risk patients during this public health emergency, and possibly those to come in the future. So we're hoping that you might be interested in some additional work around chronic care management, and maybe that's an affinity group that you would like to see us get set up. So it looks like we're going to go ahead and open up the poll. And I see some chat going on. Mary, is there anything that I need to address out of the chat box?
No. We are talking about passer screening for psychiatric patients into skilled facilities. So you're good to go. So everybody go ahead and participate in the poll about, using some telehealth to further discuss chronic care management, implementation and the codes and how to processes, all of that kind of stuff. If you're interested in.
The other thing, Mary, that we might be able to address during an affinity group would be more information about remote monitoring, remote physiological monitoring, getting paid for the monitoring that can be done. Because again, I think that's going to be a big new opportunity, revenue generating opportunity for our clinics as well.
I think so, and that brings up another point that we've been talking also about diabetes prevention programs and doing virtual diabetes prevention. So when we're talking like chronic care management, like Deb just said, we're talking kind of the gamut of things that are going to be available specifically in that chronic care group and the chronic disease group. So. All right, thank you everybody for your interest in that. So we'll be using these results next week as we kind of reevaluate the affinity group and what we need to do. Maggie is talking in chat that she heard recently on a CMS call from physician teams saying they've tried annual wellness visits and patients prefer doing these in clinics when available. So I don't know if anybody has any other feedback on that.
Sorry, this is Eric. I had a quick question. So what is that level 2 passer? Because there was a comment, sorry, just to circle back to this, there was Maggie said skilled facilities have great challenges with access or availability of psych physicians with level 2 passer, etc. What does that mean?
That is their, correct me if I'm wrong, Maggie, but that is their skilled level in the nursing home screening that they have to do, correct? Maggie, I don't know that we have you as a panelist.
Right, if positive level 1. I'm sorry. I guess maybe we can speak offline. I don't understand what any of those terms mean. The only thing I understand is psychiatrist and antipsychotic. The other stuff is...
It's nursing home lingo, so we'll talk about it on Monday.
Awesome.
Yeah, and Maggie is a Mountain Pacific employee, so we'll connect you with her and we'll see what we can do there.
Great.
Okay, so we just wanted a couple of questions out to the group. So some feedback from you if there's any other specialty areas that you need assistance with. We have thrown around the idea, there's some talk out there about EMS and the role of EMS and how telehealth can be utilized in pre-hospital care. There's some models going on actually in New York City where they have used telehealth to help triage or potentially not even transport patients to the hospital as part of kind of their mitigation strategy around hospital patient flow and throughput and whatnot. So there are some models like that starting to spring up as a result of the public health emergency. So that one has come up. So if there's interest in that, please let us know. And then what successes have you had through your implementations? We know a lot of you are using telehealth. So if anybody would like to chime in for a minute, we're just down to the last few minutes. So if you have anything that you would like to share with the group, or you can send it out to us and we'll put it on our website. And then we also want everybody to be thinking about your plan to sustain telehealth services in your practice. So is this going to be a short-term thing, or are you thinking more long-term? And how can we help support that? Realizing, of course, that a lot of it is dependent on reimbursement issues. So the last piece that we have is we have a couple of reevaluation questions for you. These should look familiar. We asked all of you these questions when you registered for the affinity group. So this is kind of our remeasurement of our own progress here, and to make sure that we met the goals that we had set forth to hopefully support you all in expanding some services, reducing some barriers, and getting assistance to help you with any issues. So go ahead and we will wrap up that last polling questions. And in the meantime, if you have anything to share about your experience implementing telehealth, or any continued barriers, those kinds of things, feel free to let us know in the chat. I don't have any Jeopardy music to play, so.
So sing.
Otherwise, we're gonna have to listen to Dr. Arzubi talk some more too.
No, you don't want that. Oh, somebody just said mercy. Just said mercy. No more. Oh.
It wasn't me. All right, we'll give you about 30 more seconds here. Okay, I'm gonna go ahead and end the poll. Share some results. It looks like several of you that answered were able to get some telehealth services going since COVID-19, so we're glad to hear that. It looks like everybody kind of encountered the unease with technology issues, so hopefully we've helped with some of that. And technical applications, connectivity, and equipment seems to be an area where people are maybe still having some issues. So that'll again be something we need to consider maybe going into some next sessions here. So, all right, good deal. Okay, so we still have our website. We're going to keep that going. Not sure when it'll ever stop, so it'll be a resource that's around for a while. If you have questions or anything, you can let us know either through the website or just email us directly. Our sessions, we just want to thank you all for your participation. We've had really good participation and interaction in all of our sessions, and we definitely appreciate that. We appreciate any feedback you have. And I wanted to just also note that we are starting post-acute care, so long-term care, assisted living, home care, hospice. We're starting an affinity group for that specific care setting. We're going to start that on Monday at 10 a.m. Mountain Time. The first session will be implementing the telehealth overview, so please feel free to send out the registration information to your friends, or if you would like it yourself and haven't received it yet, we've tried to blast that out this last couple weeks. So if you'd like information on that, please let us know. We're going to start with 2 sessions and go from there based on participation and activity. So if you need help or if you know colleagues that need help, let us know. And feel free to contact our subject matter experts on any of these issues. Then they'll get back to you promptly. We do have one last question in the chat from Karen. Reached out to some of the Med Advantage plans here in Hawaii, was told they are still requiring video also. So Medicare Advantage is still requiring video also in Hawaii. I'm not sure what to say about that. We'd have to probably advocate to the Medicare Advantage plans, because those are a little bit more privately ran than the federal. Anybody else have any other input on that? Or heard anything differently in our other states? I have not. Oh, go ahead.
No, this is Eric. I wonder, because I like causing trouble. I wonder if there's any way you can call the local senator and just alert them to that and the impact it's having on access to care, or the governor's office there.
For sure. You might have to advocate a little bit, and we've done some advocating with our senators for telehealth. So if you need some help with that, Karen, let us know. Maggie, who's also on this call, is one of our Hawaii staff, so she may be able to help you out there. And Deb, we will get you the information on the post-acute care webinars. Okay. All right, all. Thanks for your time today. Have a great weekend, and all of your input and participation is greatly appreciated.
Thank you.
Thank you. Stay safe, everyone.